Good day to everyone. I will be discussing part 1 of the endocrine system consisting of the pineal gland, pituitary gland, thyroid gland, and the parathyroid glands. In this lecture, we will discuss the endocrine organs in the cranial cavity as to location and related intracranial structures, hormones produced, supporting structures, and neurovascular supply. We will describe the endocrine organs in the anterior neck as to location, related structures at its surroundings, hormones produced, neuroendocrine control, vascular supply, and drainage. We will also discuss the features of common clinical conditions. The endocrine system consists of specialized structures that secrete hormones, including discrete ductless endocrine glands such as the thyroid gland, isolated and clustered cells of the gut and blood vessel walls, and specialized nerve endings. Hormones are organic molecules that are carried by the circulatory system to distant effector cells in all parts of the body. Hormones influence metabolism and other processes such as the menstrual cycle, pregnancy, and parturition or giving birth. I will first discuss the pituitary gland. The pituitary gland is a small, oval structure attached to the undersurface of the brain by the infundibulum. The gland is well protected by virtue of its location in the sella turcica of the sphenoid bone. The pituitary gland is also called as hypophysis cerebri, and these are top views of the sella turcica or the pituitary fossa. The sella turcica, from the Latin word which means Turkish saddle, is a saddle-like bony formation on the upper surface of the body of the sphenoid, which is surrounded by the anterior and posterior clinoid processes. Clinoid means bedpost, and the four processes, 2 anterior and 2 posterior, surround the hypophyseal fossa, the bed of the pituitary gland, like the posts of a 4-poster bed. The sella turcica is composed of 3 parts. First is the tuberculum sellae, or the horn of the saddle, a variable slight to prominent median elevation forming the posterior boundary of the prechiasmatic sulcus in the anterior boundary of the hypophyseal fossa. Second is the hypophyseal fossa, aka pituitary fossa. It's a median depression, or the seat of the saddle, in the body of the sphenoid that accommodates the pituitary gland. The third is the dorsum sellae, or the back of the saddle. It's a square plate of bone projecting superiorly from the body of the sphenoid. It forms the posterior boundary of the sella turcica, and its prominent superolateral angles make up the posterior clinoid processes. This is the superior view of the pituitary gland. It is related anteriorly to the sphenoid sinus. Posterior to the pituitary gland are the dorsum sellae, the basilar artery, and the pons. Superior to the pituitary gland, we can find the diaphragma sellae. It is a small circular fold of dura mater that forms the roof of the sella turcica. A small opening in its center allows passage of the stalk of the pituitary gland. Inferiorly, the pituitary gland is related to the body of the sphenoid with its sphenoid air sinuses, while lateral to it are the cavernous sinuses and their contents. The pituitary gland is divided into an anterior lobe or adenohypophysis and a posterior lobe or neurohypophysis. The anterior lobe is subdivided into pars anterior, sometimes called the pars distalis, and the pars intermedia, which may be separated by a cleft that is a remnant of an embryonic pouch. A projection from the pars anterior, the pars tuberalis, extends up along the anterior and lateral surfaces of the pituitary stalk. Because the hormones produced by the gland influence the activities of many other endocrine glands, the pituitary gland is often referred to as the master endocrine gland. For this reason, it is vital to life. Shown in this table are the different hormones secreted or produced in the different parts of the pituitary gland. let us talk about the hypothalamic-pituitary axis. The hypothalamus can be considered the coordinating center of the endocrine system. It consolidates signals derived from upper cortical inputs, autonomic function, environmental cues such as light and temperature, and peripheral endocrine feedback. In turn, the hypothalamus delivers precise signals to the pituitary gland, which then releases hormones that influence most endocrine systems in the body. Specifically, the hypothalamic-pituitary axis directly affects the functions of the thyroid gland, the adrenal gland, and the gonads, as well as influencing growth, milk production, and water balance. As mentioned earlier, the pituitary gland influences the activities of many other endocrine glands. It is itself controlled by the hypothalamus, and the activities of the hypothalamus are modified by information received along numerous nervous afferent pathways from different parts of the central nervous system and by the plasma levels of the circulating electrolytes and hormones. I will now be discussing the different pituitary gland hormones. First is the growth hormone, also known as somatotropin. It is the most abundant anterior pituitary hormone, and it is produced by the pituitary somatotroph cells. Its production begins early in fetal life and continues throughout life, although at a progressively lower rate. Its secretion is directly controlled by hypothalamic and peripheral factors acting on somatotrophs. Hypothalamic growth hormone releasing hormone, or GHRH, stimulates growth hormone secretion. Somatostatin, or SRIH, inhibits growth hormone secretion. GHRH and SRIH act by binding to specific cell surface receptors on somatotroph cells. The growth hormone stimulates linear growth in children by acting directly and indirectly via the synthesis of insulin-like growth factor 1 on the epiphyseal plates of long bones. In adults, it increases lipolysis and lipid oxidation, which leads to mobilization of stored triglyceride. It also stimulates protein synthesis. It antagonizes insulin action, which may lead to glucose intolerance, diabetes, and features of metabolic syndrome when growth hormone is in excess. It also helps in the retention of phosphate, water, and sodium. These target tissue actions result in maintenance of adult cardiac function, glucose homeostasis, maintenance of bone mineralization, appropriate balance of adipose lipogenesis and lipolysis, and skeletal muscle anabolism. All these functions are attenuated in patients with growth hormone deficiency, and replacement of growth hormone reverses the abnormalities. Clinical correlation. Growth hormone excess can result into either acromegaly or gigantism. Acromegaly is a disorder caused by excessive growth hormone production from the anterior pituitary gland, resulting in excessive growth of body tissues and other metabolic dysfunctions. Adult patients with acromegaly have the characteristic facial features of a large lower jaw, prominent forehead, and large hands and feet. This occurs after the growth plates are fused, distinguishing acromegaly from gigantism, which occurs before the fusion of growth plates. Growth hormone deficiency is a frequent cause of dwarfism. The hypothalamic pituitary axis maintains the levels of growth hormones in the body, which then directly or indirectly, through insulin-like growth factor 1, stimulates bone elongation and growth of soft tissue and cartilage. Lower levels of IGF-1 are linked with short stature. Next is prolactin. It is produced in the lactotroph cells of the anterior pituitary gland. Its primary functions are milk production and development of mammary glands within breast tissues. It stimulates the breast alveolar epithelial cells to synthesize milk components. Prolactin is necessary for the secretion of milk by the cells of the alveoli. The level of prolactin in the blood increases markedly during pregnancy, and it stimulates the growth and development of the mammary tissue in preparation for the production of milk. However, milk is not secreted then because progesterone and estrogen, the hormones of pregnancy, block this action of prolactin. After delivery, levels of progesterone and estrogen fall rapidly. Prolactin is no longer blocked and milk secretion begins. When a baby suckles, the level of prolactin in the blood increases and stimulates production of milk by the alveoli. Clinical correlation: lactotroph adenoma or prolactinoma. Prolactin-secreting tumors of the pituitary gland are called prolactinomas. It is the most common secretory tumors of the pituitary gland, accounting for up to 40% of total pituitary adenomas. Prolactinomas cause a wide variety of symptoms either due to mass effect of the tumor or due to hypersecretion of prolactin. Based on the size of the tumors, prolactinomas can be classified as microprolactinoma, which is smaller than 10 millimeters, macroprolactinoma, larger than 10 millimeters, or giant prolactinoma, larger than 4 centimeters. Next is ACTH, or the adrenocorticotropic hormone. It is a tropic hormone produced by the anterior pituitary. Tropic hormones indirectly affect target cells by first stimulating other endocrine glands. The hypothalamic pituitary axis controls it. ACTH acts on its target organ, which is the adrenal cortex, and it regulates cortisol and androgen production. Clinical correlation: Cushing syndrome, aka hypercortisolism, is caused by prolonged exposure to high circulating levels of cortisol. The most common cause of Cushingoid features is iatrogenic corticosteroid use, while some herbal preparations can also increase circulating corticosteroid levels, leading to Cushing syndrome. Endogenous Cushing syndrome results from excessive production of cortisol by adrenal glands. It can be ACTH dependent or ACTH independent. ACTH dependent Cushing is caused by ACTH secreting pituitary adenomas, aka Cushing disease, and ectopic ACTH secretion by neoplasms, while ACTH independent Cushing syndrome can be caused by adrenal hyperplasia, adenoma, and carcinoma. Cushing disease is ACTH-dependent cortisol excess due to a pituitary adenoma, and it is responsible for 80% of endogenous Cushing syndrome. Please take note of the difference between Cushing syndrome and Cushing disease. TSH, or thyroid stimulating hormone. It is a glycoprotein hormone produced by the anterior pituitary. The primary stimulus for thyroid hormone production by the thyroid gland is TSH. It also exerts growth effects on thyroid follicular cells, leading to enlargement of the thyroid. The hypothalamic pituitary axis regulates TSH release. Specifically, neurons in the hypothalamus release TRH, or thyroid-releasing hormone, which stimulates thyrotrophs of the anterior pituitary to secrete TSH. TSH in turn stimulates thyroid follicular cells to release thyroid hormones in the form of T3 or T4. Clinical correlation: Graves' disease is an autoimmune condition that most commonly affects young women under the age of 40. The hallmark about the disease is the presence of autoantibodies that exert TSH-like effects, called thyroid-stimulating antibodies or TSIs. TSIs stimulate TSH receptors on thyroid follicular cells, leading to both hyperthyroidism and thyroid gland enlargement, hence a goiter. As T3, T4 levels increase, TSH goes down through negative feedback inhibition. In addition to the classical signs and symptoms of hyperthyroidism, Graves' disease also causes ophthalmopathy, which manifests as exophthalmos or bulging eyes, eye irritation, double vision, and possibly vision loss. Graves' ophthalmopathy most likely happens due to TSIs binding to receptors on the soft tissues and muscles behind the eyes. This initiates an inflammatory cascade that causes ocular symptoms to occur. Next is TSH-secreting pituitary adenoma. A functioning pituitary adenoma is a pituitary tumor that secretes active hormones. It usually arises from prolactin-secreting cells, also known as lactotrophs. It can also arise from TSH-secreting thyrotrophs, leading to a rise in TSH levels. TSH-secreting adenomas are often macroadenomas that not only produce excessive amounts of TSH but also create mass effects on adjacent structures. Patients usually complain of compressive symptoms such as headaches and vision problems, as well as symptoms of hyperthyroidism. High TSH causes the thyroid gland to enlarge, and patients typically develop a goiter. A non-functioning pituitary adenoma usually arises from gonadotrophs, also known as gonadotropin-secreting cells. Healthy gonadotrophs secrete active LH and FSH consisting of both alpha and beta subunits. In contrast, a non-functioning pituitary adenoma secretes an inactive form of gonadotropins that has the alpha chain but lacks the active beta subunit. Symptoms usually do not occur until the tumor becomes large enough to compress adjacent structures. Common compressive symptoms include headaches and vision problems. Additionally, the large mass might compress the adjacent pituitary cells, leading to decreased TSH as well as other pituitary hormones. A drop in TSH levels might lead to hypothyroidism if the tumor is not adequately managed. Follicle-stimulating hormone, or FSH. This is a hormone produced by the anterior pituitary in response to gonadotropin-releasing hormone from the hypothalamus. The hypothalamus secretes gonadotropin-releasing hormone, which stimulates the anterior pituitary to release FSH and LH. In females, FSH receptors are located in the granulosa cells of the ovaries. In males, FSH receptors are found in the Sertoli cells of the testes. FSH plays a role in sexual development and reproduction in both males and females. Clinical correlation: Polycystic ovarian syndrome. Polycystic ovarian syndrome, or PCOS, is a syndrome characterized by elevated androgens, polycystic ovaries, and anovulation. Patients with PCOS often present with hirsutism, obesity, insulin resistance, menstrual irregularity, and infertility. In PCOS, the LH to FSH ratio is skewed due to persistently rapid GnRH pulses. These GnRH pulses lead to an increased LH-FSH ratio, and this skewed ratio leads to the theca cells of the ovaries producing excess androgen, while the granulosa cells do not produce enough aromatase to convert the androgens to estradiol. Hypogonadotropic hypogonadism. In cases of amenorrhea with low levels of FSH and LH, the fault lies with either the hypothalamus or the pituitary gland. Next, stress-induced hypogonadotropic hypogonadism. When calorie intake falls short of energy expenditure, the physiological stress decreases hypothalamic GnRH pulse frequency and amplitude, leading to low FSH and LH levels. This explains the anovulation and amenorrhea that can occur in female athletes and individuals with eating disorders due to lack of adequate caloric intake or excessive exercise. Premature ovarian failure occurs when ovarian failure and menopause occur before age 40. When this happens, FSH levels are elevated due to the lack of negative feedback from the ovaries. Although there may be multiple genetic causes, most cases are idiopathic. Turner syndrome is the most common genetic disorder causing premature ovarian failure. Turner syndrome is caused by the loss of an X chromosome. Girls with Turner syndrome will present with primary amenorrhea and underdeveloped ovaries and elevated FSH levels. Pituitary adenomas can develop from any of the cell types in the pituitary. pituitary adenomas derived from gonadotropic cells are most often non-functioning or function within normal hormone levels and are diagnosed due to symptoms from mass effect rather than hormone secretions. However, in sporadic, these tumors can secrete excess FSH and or LH and can cause ovarian hyperstimulation. Luteinizing hormone or LH. This is a glycoprotein hormone that is co-secreted along with FSH by the gonadotropin cells in the anterior pituitary. LH release is stimulated by GnRH and inhibited by estrogen in females and testosterone in males. It has various functions which differ between men and women. In both sexes, LH contributes to the maturation of primordial germ cells. In men, LH causes Leydig cells of the testes to produce testosterone. In women, LH triggers the creation of steroid hormones from the ovaries. LH helps regulate the length and order of the menstrual cycle in females by playing roles in both ovulation and implantation of an egg in the uterus. Clinical correlation: testicular dysfunction in chronic kidney disease. Low libido or libido, potency, and testicular size are all signs of testicular dysfunction. In end-stage renal disease, all these signs can present. Testosterone concentration in the plasma and how quickly testosterone production takes place are usually low in patients with chronic kidney disease. Spermatogenesis has been noted to be either lowered or completely absent as well. After renal transplantation, the changes noted above can be reversed and returned to normal. Studies have shown that this testicular dysfunction and altered testosterone concentration results from higher levels of LH in the plasma and lower amounts of secretory LH pulses seen in men with end-stage renal disease when compared to healthy subjects or men who underwent a successful renal transplant. This fact is significant because the pulsatile secretion of LH is necessary for gonadotropin receptors of the testes to function properly. Furthermore, sustained high levels of LH in the blood and testes can cause a loss of gonadotropin receptors in the testes. Hypogonadotropic hypogonadism in males. Hypogonadism is impaired testicular function, and this can occur due to a problem with the testes, also known as primary hypogonadotropic hypogonadism, or due to a problem with the hypothalamic pituitary gonadal axis, aka secondary hypogonadotropic hypogonadism. Men with hypogonadotropic hypogonadism have low levels of androgen in the plasma, as well as a lack or delay of sexual maturity, which can cause symptoms such as lack of libido, depression, increase in adipose tissue, and diminished erectile function. Patients with hypogonadotropic hypogonadism usually have an issue with GnRH signaling, which then causes a decrease in FSH and LH secretion. This decrease in FSH and LH contributes to both decreased androgen levels as well as reduced spermatogenesis. Studies have shown that giving these patients pulsatile GnRH or LH and FSH can help increase spermatogenesis and thus increase the sperm concentration in the ejaculate. Even then, most couples will need ART to achieve pregnancy. Melanocyte-stimulating hormone or MSH. It is produced and secreted into the bloodstream by the anterior pituitary. It regulates pigment or melanin production in the skin. It also mediates immunity and inflammation and is responsible in appetite regulation or suppression. Oxytocin is a nonapeptide hormone best known for its role in lactation and parturition. The word oxytocin was coined from the Greek words meaning quick birth after its uterine contracting properties were discovered by Dale in 1906. Shortly thereafter, the milk ejection property of oxytocin was described. Oxytocin is primarily synthesized in magnocellular neurons of the paraventricular and supraoptic nuclei of the hypothalamus. The bulk of the peptide is transported to the posterior pituitary where it is released to regulate parturition and lactation. Vasopressin or antidiuretic hormone is a nonapeptide synthesized in the hypothalamus. Science has known it to play essential roles in the control of the body's osmotic balance, blood pressure regulation, sodium homeostasis, and kidney functioning. ADH primarily affects the ability of the kidney to reabsorb water. When present, ADH induces expression of water transport proteins in the late distal tubule and collecting duct to increase water reabsorption. Several disease states arise when the body loses control of ADH secretion or responds to its presence. Clinical correlation. Syndrome of inappropriate ADH or SIADH occurs when ADH is released in excessive unregulated quantities. SIADH results in excess water reabsorption and thus creates delusional hyponatremia. Although water is retained in quantities greater than the body's needs, these patients typically remain euvolemic and do not exhibit features of the third spacing of fluids such as edema. Settings in which SIADH arises include malignancies, most often by autonomous production of ADH by small cell lung cancer, central nervous system disturbances, such as stroke, hemorrhage, infection, trauma, etc. Drugs such as selective serotonin reuptake inhibitors, carbamazepine, and others. Surgery most likely secondary to pain, and more. A failure of ADH secretion causes central diabetes insipidus, the more common form and often seen after brain trauma or surgery that damages either the hypothalamus or posterior pituitary. In this scenario, ADH levels are low. Thus, the collecting tubules are impermeable to water, resulting in excess water excretion. In nephrogenic diabetes insipidus, ADH secretion is normal, but there is a defect in the V receptor or other signaling mediators that makes the kidneys unresponsive to ADH. In either disease, the net effect is increased excretion of water. The depletion of water causes the production of large volumes of dilute water and the concentration of body fluids, leading to hypernatremia and hyperosmolarity. This status results in polyuria, polydipsia, and the effects of electrolyte imbalances that ensue. The blood supply of the pituitary gland are derived from the superior and inferior hypophyseal arteries, branches of the internal carotid artery. The veins drain into the intercavernous sinuses. Clinical correlation. Simmons disease or panhypopituitarism. It is also known as pituitary cachexia. It is a syndrome ascribed to destruction or physiological exhaustion of the pituitary gland, chiefly the anterior portion. It may be caused by embolic infarction, tumor, syphilis, tuberculosis, metastatic abscesses, and inflammation. It is clinically characterized by cachexia, premature senility, atrophy of the gonads and genitalia, with amenorrhea, atrophy of the breasts, loss of pubic and axillary hair, loss of libido, integumental changes, chiefly dryness of the skin, anorexia and constipation, hypotension, muscular weakness, hypoglycemia, decreased sugar tolerance, and lowered basal metabolism. Pituitary tumors may extend superiorly through the aperture in the diaphragma cellae or cause it to bulge. These tumors often expand the diaphragma cellae, producing disturbances in endocrine function early or late, that is before or after enlargement of the diaphragma cellae. Superior extension of a tumor may cause visual symptoms owing to the pressure on the optic chiasm, the place where the optic nerve fibers cross. Bitemporal hemianopsia is a loss of the lateral halves of the fields of vision of both eyes, that is, loss of function of the medial half of both retinas. This condition is most commonly produced by a tumor of the pituitary gland exerting pressure on the optic chiasma. Let us now talk about the pineal gland. The pineal body is a small, cone-shaped glandular structure that lies between the superior colliculi. It is attached by a stalk to the region of the posterior wall of the third ventricle. The pineal commonly calcifies in middle age, and thus it can be visualized on radiographs. The pineal gland, for example, is calcified in 50% of normal adults. The pineal consists essentially of groups of cells, the pinealocytes, supported by glial cells. The gland has a rich blood supply and is innervated by postganglionic sympathetic nerve fibers. The pineal gland can influence the activities of the pituitary gland, the islets of Langerhans, of the pancreas, the parathyroids, the adrenals, and the gonads. The pineal secretions produced by the pinealocytes reach their target organs via the bloodstream or through the CSF. Melatonin is the main hormone secreted by the pineal gland. It was discovered and isolated from bovine pineal in 1958 by Aaron Lerner. Melatonin inhibits secretion of gonadotropin-releasing hormone. It plays a role in the circadian rhythm of the body's response to light and dark cycles. Melatonin is mainly synthesized by the pinealocytes. Synthesis and secretion is enhanced by darkness and inhibited by light. Luminous information is transmitted from the retina to the pineal gland through the hypothalamus. In humans, its secretion starts soon after sundown, reaches a peak in the middle of the night between 2 and 4 in the morning, and decreases gradually during the second half of the night. Nearly 80% of the melatonin is synthesized at night. Its serum concentrations vary considerably with age, and infants secrete very low levels of melatonin before 3 months of age. Melatonin secretion increases and becomes circadian along with child development. In 3-year-old children, a stabilization of the sleep-wake rhythm is observed, which corresponds to a regular melatonin secretion rhythm. Melatonin regulates circadian rhythm, such as the sleep-wake rhythm, neuroendocrine rhythms, or body temperature cycles. Ingestion of melatonin induces fatigue, sleepiness, and a diminution of sleep latency. Disturbed circadian rhythms are associated with sleep disorders and impaired health. For example, children with multiple developmental, neuropsychiatric, and health difficulties often show melatonin deficiency. When circadian rhythm are restored, behavior, mood development, intellectual function, health, and even seizure control may improve. Studies suggest its early role in CNS development. It is also involved in blood pressure and autonomic cardiovascular regulation and immune system regulation. It also has retinal functions and is responsible in detoxification of free radicals and antioxidant actions. Concerning psychiatric disorders, secretion disturbances of the pineal gland have been described in child and adult psychiatry, with notably in most studies a decreased nocturnal melatonin secretion observed in major depressive disorder, bipolar disorder, schizophrenia, or autism spectrum disorder. It is noteworthy that increased melatonin levels were found when clinical therapeutic benefits were observed following the use of antidepressants. Sleep disorders mostly increase sleep latency, reduce total sleep, and nocturnal awakenings with insomnia are observed in 50 to 80% of individuals with autism. It is noteworthy that sleep problems are not specific of autism and are also observed in children with intellectual disability associated or not with autism. It is well known that melatonin as an antioxidative and anti-inflammatory agent counters acute lung injury or acute respiratory distress syndrome induced by viral and bacterial infections. Melatonin can be beneficial in critically ill patients via reducing vessel permeability, inducing sedation, decreasing agitation, and increasing sleep quality. These beneficial properties of melatonin may highlight this hypothesis that melatonin may exert further clinical outcomes for COVID-19 patients. The pineal gland's blood supply is derived from the posterior cerebral artery from its choroidal branches. The internal cerebral vein drains the blood from the epiphysis cerebri. It receives sympathetic innervation from the superior cervical ganglia, parasympathetic innervation from pterygopalatin and otic ganglia. The pineal stalk of the gland also has nerve fibers along with innervation from neurons from the trigeminal ganglion. Next is the thyroid gland. The thyroid gland lies deep to the sternothyroid and sternohyoid muscles, located anteriorly in the neck at the level of the C5 to T1 vertebrae. It consists primarily of right and left pear-shaped lobes, anterolateral to the larynx and the trachea. The apices of the lobes are directed upward as far as the oblique line of the lamina of the thyroid cartilage. The base of each lobe lies below at the level of the fourth or fifth tracheal ring. The lateral lobes of the thyroid gland can be palpated deep to the sternocleidomastoid muscles. Anterolaterally, it is related to the sternothyroid, the superior belly of the omohyoid, the sternohyoid, and the anterior border of the sternocleidomastoid. Posterolaterally and medially, these are the structures related to the lobes. A relatively thin isthmus unites the lobes over the trachea, usually anterior to the second, third, and fourth tracheal rings. Anteriorly and posteriorly, these are the structures related to the isthmus. Approximately 50% of thyroid glands have a pyramidal lobe. This lobe, which varies in size, extends superiorly from the isthmus of the thyroid gland, usually to the left of the median plane. The isthmus may be incomplete. A band of connective tissue, often containing accessory thyroid tissue, may continue from the apex of the pyramidal lobe to the hyoid. The pyramidal lobe and the band develop from remnants of the epithelium and connective tissue of the thyroglossal duct. If it is muscular, it is referred to as the levator glandula thyroideae. Thyroid gland is a vascular organ surrounded by a sheath derived from the pretracheal layer of deep fascia. This tethers the gland to the larynx and the trachea and explains why the thyroid gland follows the movements of the larynx in swallowing. This information is important because any pathologic neck swelling that is part of the thyroid gland will move upward when the patient is asked to swallow. The thyroid gland is surrounded by a thin fibrous capsule which sends septa deeply into the gland. Dense connective tissue attaches the capsule to the cricoid cartilage and superior tracheal rings. External to the capsule is a loose sheath formed by the visceral portion of the pretracheal layer of deep cervical fascia. The sheath attaches the gland to the larynx and the trachea. The rounded posterior border of each lobe is related posteriorly to the superior and inferior parathyroid glands in the anastomosis between the superior and inferior thyroid arteries. The thyroid hormones, thyroxine and triiodothyronine, increase the metabolic activity of most cells in the body. The parafollicular cells produce the hormone thyrocalcitonin, which lowers the level of blood calcium. The highly vascular thyroid gland is supplied by the superior and inferior thyroid arteries. These vessels lie between the fibrous capsule and the loose fascial sheath. Usually, the first branches of the external carotid arteries, the superior thyroid arteries, descend to the superior poles of the gland, accompanied by external laryngeal nerve. They pierce the pretracheal layer of deep cervical fascia and divide into anterior and posterior branches, supplying mainly the anterosuperior aspect of the gland. The inferior thyroid arteries, the largest branches of the thyrocervical trunks arising from the subclavian arteries, run superomedially posterior to the carotid sheaths to reach the posterior aspect of the thyroid gland, where it is closely related to the recurrent laryngeal nerve. The recurrent laryngeal nerve crosses either in front of or behind the artery, or it may pass between its branches. They divide into several branches that pierce the pretracheal layer of the deep cervical fascia and supply the posterior-inferior aspect, including the inferior poles of the gland. The right and left superior and inferior thyroid arteries anastomose extensively within the gland, ensuring its supply while providing potential collateral circulation between the subclavian and external carotid arteries. In approximately 10% of people, a small unpaired thyroid ema artery or arteria thyroidea ema arises from the brachiocephalic trunk. However, it may arise from the arch of the aorta or from the right common carotid, subclavian, or internal thoracic arteries. When present, this small artery ascends on the anterior surface of the trachea, supplying small branches to it. The artery then continues to the isthmus of the thyroid gland, where it divides and supplies it. 3 pairs of thyroid veins usually form a thyroid plexus of veins on the anterior surface of the thyroid gland and anterior to the trachea. The superior thyroid veins accompany the superior thyroid arteries. They drain the superior poles of the thyroid gland. The middle thyroid veins do not accompany but run essentially parallel courses with the inferior thyroid arteries. They drain the middle of the lobes. The usually dependent inferior thyroid veins drain the inferior poles. The superior and middle thyroid veins drain into the internal jugular veins. The inferior thyroid veins drain into the brachiocephalic veins posterior to the manubrium. The lymph from the thyroid gland drains mainly laterally into the deep cervical lymph nodes. A few lymph vessels descend to the paratracheal nodes. Tracheal or paratracheal nodes lie alongside the trachea. They receive lymph from neighboring structures, including the thyroid gland. The nerves of the thyroid gland are derived from the superior, middle, and inferior cervical or sympathetic ganglia. They reach the gland through the cardiac and superior and inferior thyroid periarterial plexuses that accompany the thyroid arteries. These fibers are vasomotor, not secretomotor. They cause constriction of blood vessels. Endocrine secretion from the thyroid gland is hormonally regulated by the pituitary gland. Clinical correlation. A non-neoplastic and non-inflammatory enlargement of the thyroid gland is called a goiter. A goiter results from a lack of iodine. It is common in certain parts of the world where the soil and water are deficient in iodine. The enlarged gland causes a swelling in the neck that may compress the trachea, esophagus, and recurrent laryngeal nerves. When the gland enlarges, it may do so anteriorly, posteriorly, inferiorly, or laterally. It cannot move superiorly because of the superior attachments of the sternothyroid and sternohyoid muscles. Substernal extension of a goiter is also common. The close relationship between the trachea and the lobes of the thyroid gland commonly results in pressure on or displacement of the trachea in patients with pathologic enlargement of the thyroid. The attachment of the sternothyroid muscles to the thyroid cartilage effectively binds down the thyroid gland to the larynx and limits the upward expansion of the gland. There being no limitation to downward expansion, it is not uncommon for a pathologically enlarged thyroid gland to extend downward behind the sternum. A retrosternal goiter, or any abnormal enlargement of the thyroid gland, can compress the trachea and cause dangerous dyspnea. It can also cause severe venous compression. Excision of a malignant tumor of the thyroid gland or other surgical procedure sometimes necessitates removal of part or all of the gland. We call that hemithyroidectomy or thyroidectomy. In the surgical treatment of hyperthyroidism, the posterior part of each lobe of the enlarged thyroid is usually preserved, a procedure called near total thyroidectomy, to protect the recurrent and superior laryngeal nerves and to spare the parathyroid glands. Post-operative hemorrhage after thyroid gland surgery may compress the trachea, making breathing difficult. The blood collects within the fibrous capsule of the gland. Development of the thyroid gland begins in the floor of the embryonic pharynx at the site indicated by a small pit, the foramen cecum, in the dorsum of the postnatal tongue. Subsequently, the developing gland relocates from the tongue into the neck, passing anterior to the hyoid and thyroid cartilages to reach its final position anterolateral to the superior part of the trachea. During this relocation, the thyroid gland is attached to the foramen cecum by the thyroglossal duct. This duct normally disappears, but remnants of epithelium may remain and form a thyroglossal duct cyst at any point along the path of its descent. The cyst is usually in the neck, close or just inferior to the body of the hyoid bone, and forms a swelling in the anterior part of the neck occupying the midline. It develops as a result of persistence of a small amount of epithelium that continues to secrete mucus. As the cyst enlarges, it is prone to infection, and so it should be removed surgically. Since remnants of the duct often traverse the body of the hyoid bone, this may have to be excised also to prevent recurrence. Lastly are the parathyroid glands. The small flattened oval parathyroid glands, measuring about 6 millimeters long in their greatest diameter, usually lie external to the thyroid capsule on the medial half of the posterior surface of each lobe of the thyroid gland inside its sheath. Most people have 4 parathyroid glands. Approximately 5% of people have more. Some have only 2 glands. The superior parathyroid glands, more constant in position than the inferior ones, usually lie slightly more than 1 centimeter superior to the point of entry of the inferior thyroid arteries into the thyroid gland or at the level of the inferior border of the cricoid cartilage. The inferior parathyroid glands usually lie slightly more than 1 centimeter inferior to the arterial entry point near the inferior poles of the thyroid gland, but they may lie in various positions. The 2 inferior parathyroid glands usually lie close to the inferior poles of the thyroid gland. They may lie within the fascial sheath, embedded in the thyroid substance, or outside the fascial sheath. Sometimes, they are found some distance caudal to the thyroid gland in association with the inferior thyroid veins, or they may even reside in the superior mediastinum in the thorax. In 1 to 5% of people, an inferior parathyroid gland is deep in the superior mediastinum. Because the inferior thyroid arteries provide the primary blood supply to the posterior aspect of the thyroid gland where the parathyroid glands are located, branches of these arteries usually supply the parathyroid glands. However, they may also be supplied by branches from the superior thyroid arteries, the thyroid ima artery, or the laryngeal, tracheal, and esophageal arteries. Parathyroid veins drain into the thyroid plexus of veins of the thyroid gland and trachea. The venous drainage is into the superior, middle, and inferior thyroid veins. Lymphatic vessels from the parathyroid glands drain with those from the thyroid gland into deep cervical lymph nodes and paratracheal lymph nodes. The nerve supply of the parathyroid glands is abundant. It is derived from thyroid branches of the cervical or sympathetic ganglia. Like the nerves to the thyroid, they are vasomotor rather than secretomotor because these glands are hormonally regulated. The chief cells of the parathyroid glands produce the parathyroid hormone, which stimulates osteoclastic activity in bones, thus mobilizing the bone calcium and increasing the calcium levels in the blood. The parathyroid hormone also stimulates the absorption of dietary calcium from the small intestine and the reabsorption of calcium in the proximal convoluted tubules of the kidney. It also strongly diminishes the reabsorption of phosphate in the proximal convoluted tubules of the kidney. The secretion of the parathyroid hormone is controlled by the calcium levels in the blood. Clinical correlation. The variable position of the parathyroid glands, especially the inferior ones, puts them in danger of being damaged or removed during surgical procedures in the neck. Atrophy or inadvertent surgical removal of all the parathyroid glands results in tetany, a severe neurologic syndrome characterized by muscle twitches and cramps. The generalized spasms are caused by decreased serum calcium levels. Because laryngeal and respiratory muscles are involved, failure to respond immediately with appropriate therapy can result in death. To safeguard these glands during thyroidectomy, surgeons usually preserve the posterior part of the lobes of the thyroid gland. In cases in which it is necessary to remove all the thyroid gland, that is because of malignant disease, for example, the parathyroid glands are carefully isolated with their blood vessels intact before removal of the thyroid gland. Parathyroid tissue may also be transplanted, usually to the arm, so it will not be damaged by subsequent surgery or radiation therapy. Hyperparathyroidism. The most common clinical presentation of primary hyperparathyroidism is asymptomatic hypercalcemia. The diagnosis is usually first suspected because of the incidental finding of an elevated serum calcium concentration on biochemical screening tests. Also, primary hyperparathyroidism may be suspected in a patient with nephrolithiasis. It is diagnosed by finding a frankly elevated parathyroid hormone concentration in a patient with hypercalcemia. When the parathyroid hormone is only minimally elevated or within the normal range, but inappropriately normal given the patient's hypercalcemia, primary hyperparathyroidism remains the most likely diagnosis. Secondary hyperparathyroidism is secondary to chronic kidney disease, a condition characterized by inappropriate secretion of parathyroid hormone. Its pathophysiology is mainly due to hyperphosphatemia and vitamin D deficiency and resistance. Surgical management represents the only radical treatment of the disease. Thank you and good day.